Hello, Joshi sir.
Joshi എത്തിയിട്ടുണ്ടല്ലേ? ഇപ്പൊ നമുക്ക് തുടങ്ങാലോ. സാദിഖ് ആരംഭിച്ചു. വെൽക്കം പറഞ്ഞത്.
Respected Riyaz sir, Najima madam, all other senior members of the profession and my dear colleagues. Today we gather for monthly CME of IAP Malappuram. Today we got two distinguished speakers, Riyaz sir and Najima madam, both of them are our teachers, and we have heard that this would be an academic feast for us. More than that, for most of us, there is a nostalgic element in that because most of us studied in Calicut Medical College. During that time, they were our teachers, so we can go back to that memories also. First of all, I am welcome both Dr. Riyaz sir and Dr. Najima Riyaz to this session, and I also welcome all those attending this meeting. And now I invite Dr. K.K. Joshi sir to share the today's session. Over to Joshi sir. Thank you.
Thank you, Dr. Akbar Sadiq, Dr. Riyaz, Dr. Najima Riyaz, Dr. Akbar Sadiq, senior members of the profession, pediatricians, dermatologists, and my dear friends. Today, we are having our monthly CME. There are two talks. First talk is by Dr. Najima Riyaz on approach to pediatric dermatosis, and the second talk is by Dr. Riyaz on rash and fever in children, something new, something not very new. I don't want to be an obstacle between the cup and the lip, so I directly invite Dr. Jyoti Krishna to introduce Dr. Najima Riyaz. Over to Dr. Jyoti.
Thank you, Joshi sir. Very good evening to all of you. I am very happy and proud to introduce Dr. Najima Riyaz, the Professor and Head of Department Dermatology, KMCT Medical College, Calicut, Kerala. And she was the former Professor and Head of Dermatology, Government Medical College, Calicut. And she was past President and Secretary of Indian Association of Dermatologists, Venerologists, and Leprologists. Also, she was the Dean of Medicine, Kannur University, and she was the section editor of IADVL, Concise Textbook of Dermatology. She has got many awards. She was the best teacher of South India by National IADVL for 2021. And she got IADVL Kerala Professor B.K.S. Nair Memorial Oration in May 2013. Also, she got Professor Sardari Lal Oration, Dermazone South, held at Jipmar, Puducherry in August 2014. Also, she got the Ampadi National Oration Dermacon 2016. Madam has published many papers, and she was the author of Dermatology Digest, also the co-author of many books. Also, she has contributed many chapters in various textbooks. I welcome you, ma'am. Thank you. Start now. Can you hear me?
Yes, madam. Yes, madam.
Okay. Shall I start now?
Yeah, yeah. Please.
ആർട്ടിഫിഷ്യൽ കാണിക്കണം ഇവിടെ അനിൽകുമാർ അല്ലേ
Sadik, please tell everyone to unmute, mute the audio.
Everyone except the speaker, please mute the audio. Hello?
എല്ലാവരും ഒന്ന് അൺമ്യൂട്ട് ചെയ്യോ
Mute ചെയ്യാം.
Good evening, everyone. Thank you, Dr. Jody, for the nice introduction. At the outset, I would like to thank the organizers, especially our friend, Dr. Parameswaran, and the team of IAP for inviting us for this.
Please unmute. Please unmute.
Can you hear now?
Yes.
Okay. Thank you, Dr. Jody, for the nice introduction. Good evening, everyone. At the outset, I would like to thank the organizers, especially our close friend, Dr. Parameswaran, Dr. Joshi, and the team of IAP for inviting us. So dermatoses are quite common in pediatric practice. For convenience, we can consider these under three headings: the neonatal, childhood, and adolescent dermatosis. Of course, there is no strict demarcation between these three groups. As you know, there are certain differences between the child skin and the adult skin. You can see that a child skin is much thinner and lesser elastic, and there's a loose connection between the dermis and the epidermis. And of course, the appendages are also lesser active, especially the sweat and sebaceous glands, with a different content of the different composition of the contents. And hence, a child's skin is more permeable, more penetrable, and hence more irritable. So you have to be careful while dealing with the skin of a child. Fortunately, many of the neonatal dermatoses are physiological and hence do not require much specific treatment, and most of them are self-limiting. Here you can see a whitish material sticking onto the skin surface of this newborn, which is nothing but vernix caseosa, which is the normal protective lipid covering of the newborn, which acts as a barrier to bacteria. The term is derived from the Greek vernix, meaning varnish, and caseosa, meaning cheese-like. This is in fact the most common dermatosis encountered in a neonate, characterized by a blotchy erythema topped with papules and pustules. That is Erythema Toxicum neonatorum, but there is no, actually it's a misnomer because there is no toxemia associated with this condition. This is seen in more than 50% of tame neonates. And the lesions usually develop 1 to 2 days after birth, or it involves all over the body, sparing hands and feet. It's always associated with peripheral eosinophilia. If you do a skin biopsy, you can see plenty of eosinophils. It's a differential diagnosis of Erythema Toxicum, but here you can see monomorphic pustules. And these lesions are usually present at the time of birth. These pustules gradually peel off and followed by a pigmentary stage. That is transient neonatal pustular melanosis. It's a rather rare condition. So instead of eosinophils, you will find neutrophils in this if you do a biopsy. And that's a pigmentary stage of this condition, the transient neonatal pustular melanosis. You can see some pearly white papules in a neonate. These are called milia. They're actually retention cysts of the epidermis. And sometimes these lesions are seen on the palate when they are called Epstein's pearls. And when they occur on the gum margins, these are called Bond's pearls. These also subside within a few weeks, hence no treatment is required. Sebaceous hyperplasia, usually seen on the nose and the seborrheic areas. This is due to maternal hormones in a physiological condition. Here you can see a peculiar color change in the newborn. The lower half of the body is pink and the upper half is blue. That's called the harlequin color change. This mimics the inverted flag of Monaco appearance. This is due to an abnormal vascular response due to the immaturity of the vasomotor system. Similarly, a purplish mottling in the newborn, which is called cutis murmurata, is again due to the similar mechanism, that is an abnormal vascular response to low ambient temperature due to the immaturity of the vasomotor system. The importance of this lesion is that if it persists for more than 6 months, to rule out underlying conditions like Down syndrome, cretinism, neonatal LE, Cornelia-de-Lange syndrome. Mongolian spots are will be familiar to all of you, usually seen in the lumbosacral region. And usually these lesions subside within 1 to 5 years. But progressive Mongolian spots, as in this case, you have to look for underlying lysosomal storage diseases like Hurler or Hunter syndrome. Sometimes babies may be born with such a collodion, called collodion babies, a plastic sheet-like membrane or covering the skin. But this can be physiological or pathological. In physiological cases, this membrane will peel off, leaving normal skin. That's called the lamellar exfoliation of the newborn. But sometimes it can be pathological. When this peel off, you will get an ichthyotic skin of varying degrees of ichthyosis can develop. And this is the extreme form of ichthyosis, that the harlequin fetus, which is incompatible with life. And this baby was born with such extensive hemangiomas with soft tissue hyperplasia, that is Klippel-Trenaunay-Weber syndrome. It was incompatible with life and she's died soon after birth. Infections and infestations are very common in the childhood. This girl presented with such crusted lesions on the face, along with the constitutional symptoms of a few days' duration. And the clue which clinches the diagnosis is the characteristic color of the crust, that is honey-colored. It's very typical of impetigo contagiosa, which is a mixed infection by staph and streptococcus. Another feature of the crust is the stuccoed appearance of the crust. This lesion may look like impetigo, but you can see that the color of the crust is more chocolate colored. Problem. This is chocolate colored crust that is typical of ecthyma, which is a ecthyma, which is a deep form of impetigo. Here you can see that the crusts are more adherent, and when you remove the crust, you will find ulcers with a purulent base. Local cleaning is very important for impetigo and ecthyma. That is cleaning with saline or dilute potassium permanganate, that is Conde solution. This is how you prepare saline. In 2 glasses of water, add 1 teaspoon salt. Take a piece of cloth, fold it 4 times, dip in this solution and apply for 10 to 15 minutes. Soda bicarb 5% can be used for thick to remove thick crusts, and acetic acid is mainly used for Pseudomonas. And after cleaning, you have to apply topical antibiotics like mepirocin and or sodium fusidate. Systemic antibacterials are not required in all cases. These are required for when there is associated constitutional symptoms or regional adenopathy, immunosuppression. And all facial lesions also you have to give systemic antibacterials. And these are the preferred ones, which are effective for the gram-positive organisms, the ampicillin, cloxacillin, macrolides, or ceftriaxone. This lesion may look like ecthyma, but you can see these are wedge-shaped lesions with a raised margin, and hemorrhagic crusts are seen. It is called ecthyma gangrenosum, which is seen in Pseudomonas septicemia. This could be a complication of impetigo. These 2 children presented with sudden onset of generalized erythema and tenderness, followed by peeling of the skin. You can see a peculiar wrinkling in the perioral region. But in spite of the extensive lesion, you can see that the mucosae are not involved. Mucosae are spared. So that is staphylococcal scalded skin syndrome or Ritt's disease. This is the type of scaling you get in this disease, mimicking potato chips. That's called the potato chip discommission. And this due to the exotoxin released by Staph aureus group 2 5 step 71. It's called the epidermolysin or exfoliating. The most important differential diagnosis of Ritt's disease is toxic epidermal necrolysis or Lyle's disease, which is almost always drug-induced. You can see this is the case of toxic epidermal necrolysis. You can easily differentiate from Ritt's disease by the presence of necrosis of the skin with a charred appearance and peeling, and the extensive involvement of the mucosa. So when you find intensely pruritic lesions in the interdigitals, the diagnosis is easy, that is scabies. This is a case of these are cases of infected scabies. And that's the causative organism, Sarcoptes scabiei var hominis, which is an arachnid, which forms burrows like this in the stratum corneum. If you can imagine a circle intersecting the sites of involvement of scabies, that's called the circle of Hebra. That's interdigitals, wrists, elbows, axillae, waistline, genitals. So this is the type of scabies you get in younger children, exactly mimicking atopic dermatitis, that excoriated lesions on the cheeks, as well as eczematous lesions of the legs. That is called eczematous scabies. Sometimes you may find children with intense pruritus but no lesions, and the pruritus will be worse at night. That is clean scabies. And this type of scabies is common in doctors as well. And babies can get scabies from infected pet animals like this. They develop, that's called scabies mangae or animal scabies. This is due to the animal species of mites. It's a rare form of scabies mimicking psoriasis. You can see thick scales, crusting and scaling. especially on the palms and the elbows, exactly mimicking psoriasis. That is a crusted scabies or Norwegian scabies, usually seen in children with mental retardation, peripheral neuropathy, or immunosuppression. Still, the gold standard for treating scabies is permethrin 5% cream, overnight application, single application overnight. About 10 to 12 hours you have to apply on the skin below neck. Ivermectin cream is a new addition in this, equally effective. And the systemic drug for scabies is ivermectin, given in a dose of 200 microgram per kg as a single dose. And it should not be given in children below 3 years. Pediculosis is a common problem in school-going children, and this is just to show the extreme form of protection of children by mothers who are afraid of pediculosis. Of course, that's a cartoonist view. So what's this fierce-looking creature? This is nothing but the head louse or Pediculus humanus capitis, the causative agent of pediculosis. So you can see plenty of nits and lines in the scalp. The problem with pediculosis is the recurrent pyoderma of the scalp due to persistent scratching. This can also transmit certain diseases like epidemic typhus and relapsing fever. And the gold standard for treating pediculosis now is ivermectin shampoo to be applied for 10 minutes on the scalp and then just wash it off. And another alternative is permethrin 1% lotion. Viral infections are also common in children. Here you can see discrete vesicles with an areola of erythema, mainly on the hands, feet, and the oral mucosa. That is the hand-foot-mouth disease caused by Kawasaki A16 and enterovirus 71. And if it's due to enterovirus, there is a chance of CNS complication. The transmission is mainly fecal-oral. Since it is a self-limiting problem, there is no need for any specific treatment. Here you can see pearly white papules with central umbilication, very typical of molluscum contagiosum, which is caused by an intermediate pox virus. Treatment is easy, that is extraction of the molluscum bodies, also known as the Henderson Patterson bodies, by making a slit on the surface with a needle and squeeze out the molluscum bodies, then apply phenol or tincture iodine. But when you find molluscum, extensive molluscum or giant lesions, always look for underlying the immunosuppression. These two children had leukemia. Warts are also common in pediatric age group. So here you can see skin-colored papules with a rough surface. These are caused by human papillomavirus or HPV. When you find grouped vesicles on an erythematous base, especially in the perioral region, that is herpes labialis caused by HSV1. The HSV1 is a herpes simplex virus 1, which can also cause such lesions like herpetic gingivostomatitis, characterized by hemorrhagic blisters in the lips and oral cavity. So that's an inverted Christmas tree. So in this condition, you get a rash in this pattern. So you can see oval lesions with the colorative scales distributed in this inverted Christmas tree pattern. So it is classically described for pityriasis rosea. It's a viral infection caused by human herpes virus 7. And this is the earliest lesion of pityriasis rosea called the Herald Patch. This may be mistaken for a fungal infection. This is how the lesions develop. You can see the Herald Patch here. This initial lesion, after a few days, you get the similar smaller lesion, the exanthem of pityriasis rosea. It may last for 6 to 8 weeks. Fungal infections are common in children who stay in hostels or who share bath towels with adults. And the commonest is dermatophytosis or the ringworm infection caused by these dermatophytes like trichophyton, microsporum, and epidermophyton. So that is a dermatophyte infection of the groins. Tinea cruris you can find could be annular or arciform lesions with a peripheral activity and a central clearing. That's a tinea corporis. You can see the peripheral activity. This is what happens if you give steroids or steroid antifungal combination for tinea. It will alter the picture of the lesion. The typical annular pattern is lost, and this will lead to spread of infection as well as a persistence of lesions. So whenever you suspect tinea, better never give a combination or steroid, give only plain antifungal creams. So this is the steroid modified tinea called tinea incognito, or tinea in disguise. Tinea capitis is very common in this age group, in the childhood stage. But this is a non-inflammatory type of tinea characterized by multiple patchy alopecia with broken off hairs. And sometimes you get the inflammatory type of tinea called chirium. This is seen in those who have contact with pet animals like dogs. This is from a zoophilic fungus. It's an animal source. This is characterized by boggy swellings with multiple pustules with discharging purulent discharge. There are a lot of antifungals available for treatment of tinea, right from clotrimazole to the latest fluconazole. And these are the allyl amines like terbinafine and butanafine. Systemic antifungal treatment is not required for all cases. This is mainly given for tinea incognito, extensive tinea lesions, tinea capitis, and onychomycosis. These are the preferred ones. Fluconazole is given in a dose of 3 to 5 milligram per kg weekly for 4 to 6 weeks. Itraconazole, that's a dose, 3 milligram per kg. It can be given as a pulse therapy for 1 week, then repeat next month. And terbinafine is given in this dose, 5 milligram per kg for 2 to 4 weeks. Pigmentary anomalies are sometimes seen in children. Here you can see hyperpigmented, well-defined hyperpigmented macules with scales resembling this. So what's that? That's a briny scale seen in tinea vesicolor. But sometimes you may not find any scales. So such cases you can confirm the diagnosis by doing this stretch sign. So stretch the lesion in different directions so that lesions become more prominent and scaly. That will help you to diagnose tinea vesicolor. That's a causative agent, Malassezia furfur or Malassezia globosa. And Pityrosporum is the yeast form of Malassezia. So both are same. So who is this celebrity? Those who love cricket can diagnose. That is Shane Warne with his favorite delicacy. It's a spaghetti and meatball. So what's the relevance here for this? Because it resembles the microscopic findings of scrapings from tinea vesicolor. That fungal hyphae and spores resembling spaghetti and meatball. This is another common problem in children, multiple ill-defined hyperpigmented macules without scaling. That is nutritional dyschromia, the deficiency of iron and other nutrients. Here you can see a circumscribed hyperpigmented lesion with ill-defined margins and white powdery scales. This is pityriasis alba, which is actually an endogenous eczema common in atopics. This lesion may exactly mimic pityriasis alba, but there was sensory impairment in the lesion. So that was a case of Hansen's disease, borderline tuberculosis. So the dictum is that whenever you find any hyperpigmented lesion, you have to look for sensations to rule out HD. This is a peculiar lesion with a peculiar margin. That is the lesion is present since birth. This is very characteristic of a nevus acromicus, the serrated margin. So white is a sign of purity and tranquility, but a white lesion may be depressing. Here you can see depigmented macules in this boy, mainly affecting the forearms and lips. That's an acrofacial vitiligo. Vitiligo is an autoimmune problem, may be associated with other autoimmune conditions. This is just to show you the importance of avoiding systemic topical steroid, potent steroids. See, this patient, this child, a boy with vitiligo, was treated with the potent steroids like clobetasol and developed striae like this. So always avoid such potent steroids in child's skin. This boy has extensive vitiligo, producing such a diffuse white hair. So when you find intensely pruritic lesions, papular lesions with a violaceous color, the color will give you a clue, that is lichen planus, probably because of their resemblance to lichens, which are actually symbiotic forms of fungi and algae. And there are 6 P's to diagnose lichen planus: pruritic, purple or violaceous, polygonal, plain-topped or flat-topped papules, and plaques. This is the typical nail change in lichen planus. That's a tongue-shaped extension of the posterior nail fold to the nail. This is the pterygium. And oral lesions of lichen planus may look like a white lace. So a white lace-like pattern is typical of oral LP, but it's rather uncommon in children. Red is a sign of danger. So let's see some red lesions. Here you can see well-defined erythematous plaques with silvery white scales. The diagnosis is easy, that is psoriasis. And these are some of the precipitating factors for psoriasis, like trauma, focus of infection, especially upper respiratory infection, metabolic factors like hypocalcemia, drugs like NSAIDs or antimalarials, and extremes of climate like extreme winter or extreme summer can induce psoriasis. So which sign is elicited in psoriasis here? That's an auspit sign. When you remove the scales, you will find minute bleeding points that may help to diagnose psoriatic lesions. And this is the type of psoriasis you commonly see in children. That is discrete raindrop-like lesions with characteristic silvery white scale. That is guttate psoriasis, and this often follows an upper respiratory infection. When you find greasy scales in the scalp in a child, that is called the cradle cap. Cradle cap is actually the initial stage of seborrhea. And to seborrheic dermatitis, you will find diffuse scaling with exudation and intense pruritus will be there. Atopy is a condition associated with the intensely pruritic lesions associated with asthma, bronchial asthma and rhinitis, and increased levels of serum IgE in the blood. There are several stages of atopy. This is the infantile stage of atopy, where when you get lesions mainly on the cheeks and also generalized lesions you get like this. And this is a common finding in atopics. You can see an extra fold in the lower eyelid. That's called the Denny-Morgan fold. That's the Denny-Morgan fold. So as the child grows, the lesions become more localized to flexures. So this is the type of lesion you get in childhood stage of atopy. You can see like This is the picture of lesions in infancy, generalized lesions, becoming more and more localized to flexures, and it can sometimes go on to adult stage with the localized lesions in the flexures. This is another common problem nowadays you may come across. Localized, that is acro dermatitis, which is actually localized pustular psoriasis, presenting as scaly lesions in the acral regions. In the acute stage, there may be vesicles and pustules. When the lesions subside, you get psoriasiform scaling. This is commonly seen in children who play with wet sand on beaches. This is due to the entry of the hookworm larvae, especially the Ankylostoma brasiliensis or catis or canis. This produces tortuous tracts in the skin, that is larva migrants. Alternate bands of light and dark hair is called the flax sign, or the sign de la bandra. It's very typically described in Kwashiorkor. This is due to bouts of protein malnutrition in these children. These are the skin lesions of Kwashiorkor. In mild cases, you get a mosaic skin, like cracked skin, and a flaky paint appearance in the severe forms of Kwashiorkor. So adolescence is a transitional period from childhood to adult. As per WHO, this is the age group of adolescent, 10 to 19 years. So the most common problem in adolescence is acne, which is a psychologically debilitating condition, and it's a cause for depression in many of the teenagers. Acne is due to chronic inflammation of the pilosebaceous apparatus. You can get different types of lesions in acne, like comedones, papules, pustules, nodules, and cystic lesions. The grading depends on the type of lesions. So the importance of is that many people, they consider acne as a normal part of puberty, and they do not undergo any treatment. So you have to insist patients for taking treatment for acne, otherwise it can end up in such disfiguring scars. The proper treatment is of paramount importance. By mild cases, grade 1 and 2, you can give topical agents for acne like antibiotics or keratolytics. In severe cases, grade 3 and 4 may require systemic therapy with antibiotics, preferably doxycycline or azithromycin. And isotretinoin is given for very severe forms of acne. So blister beetles are common in hostels, especially when you sleep with lights on. So this carries sacs containing an irritant called cantharidin or pederine. So when they come in contact with the skin, produce an irritant dermatitis like this, erythematous blistering lesion. It's called blister beetle dermatitis, common in those who stay in hostels. A few months back, there was a report from, I think from Kakinad, that's several cases of this blister beetle dermatitis misdiagnosed as the black fungus infection due to corona. It's also known as whiplash dermatitis because of the linear pattern. Well-defined hyperpigmented lesions, which may persist for long periods, is a characteristic of fixed drug eruption. Whenever you take the drug again, this will become erythematous, especially in the margins, and sometimes the whole lesion become erythematous and blistering. This may be mistaken for ecchymosis, but I can, you know that ecchymosis is not circumscribed like a fixed drug eruption. This is erythema multiforme. Just how to diagnose is by the appearance of the target lesions. There are 3 zones in the target: a central dusky area surrounded by a clear area and a rim of erythema. This is a severe form of erythema multiforme associated with mucosal involvement and constitutional symptoms, That's Stevens-Johnson syndrome. So in severe drug reactions, you have like a Stevens-Johnson syndrome, which is mainly due to drugs, and also TEN that I've shown previously shown this slide, toxic epidermal necrolysis. For both these conditions, you have to withdraw the suspected drug immediately, and IVIG is supposed to be life-saving in such cases. This is the dose of IVIG, 0.2 to 0.7 gram per kg daily as a single dose. For severe cases, you can give repeated dose. And cyclosporin is another drug which is used for such severe drug reactions. These are some psychological problems can also be seen in adolescents. This boy had severe intense pruritus producing such lesions, that is lichenified papules and nodules, especially in the extremities, following death of his father, and he was forced to work in a hotel. And this is another another condition, factitious cheilitis, that is induced by the patient. And this boy was put in a hostel, and being homesick, used to induce such lesions by repeated biting of the lips to go home. As adults, children are also very fond of hair. So any problem with hair can be a concern in the teenagers. Either it can be loss of hair, or alopecia, or excess hair like hirsutism or hypertrichosis. You see multiple patches of non-cicatricial or non-scarring alopecia in these children. And these are the diagnostic findings in, that is alopecia areata, and these are the diagnostic findings. You can see the exclamation mark hairs mimicking an exclamation mark, usually in the margins of the lesions. So that is a characteristic finding in alopecia areata. So alopecia areata is an autoimmune, main cause is autoimmune thyroiditis. It's the most common association. And the treatment is with topical or intralesional steroids. Persistent alopecia areata is common in Down syndrome. And this boy had for several years, he had persistent alopecia. Sometimes alopecia areata can lead to alopecia totalis. You can see how much depressed this baby after loss of the hair. These two children are continuously twisting and pulling the hair, producing an alopecia. That's called Trichotillomania, or the hair pulling tic. Some underlying psychological problem is responsible for this. And this girl, this was a 12-year-old girl who had a sad history. She developed, she was seen with the chronic abdominal pain with a recurrent nausea and vomiting following a death of her mother of about 4 years duration. Since all her investigations were normal, the CT scan was done, abdominal CT, which showed such a lesion. That's a trichobezor. So repeated evaluation, she gave history of repeatedly pulling hair and swallowing that hair. That is trichotillomania, followed by trichophagia. And this was removed by abdominal surgery. So this is the bezoar, that's a trichobezor, due to undigested hair producing a mass like this in the stomach. And the tail extended up to the jejunum. And because of the resemblance to this hair of this princess in the fairy tale Rapunzel, this condition is the Rapunzel syndrome. This trichobezor mimicking this lesion with a tail extending to the small intestine. So a therapy sails in the wings of diagnosis. So we have to diagnose first, then only the treatment depends on the correct diagnosis. So to quote Shelley, patient pessimism must always be diluted with the physician's optimism. So this is the dictum in dermatology: less is more. That is, no need for over treatment. Less medications are enough to treat dermatological problem. These are some of the take-home messages. So dermatoses are very common in pediatric practice. A child's skin is delicate and tender. Hence, you have to avoid potent topical steroids like clobetasol and halobetasol. You can remember like this, steroids ending with sol are potent, and always use mild steroids ending with son, that is hydrocortisone, fluticasone, clobetasol, metronidazole. These are all mild steroids. And if you suspect a fungal infection, never give a steroid antifungal combination. Always give a plain antifungal. So IVIGs can be life-saving in severe drug reactions like STS and TEN. An adolescent patient is a challenge, so you have to get the confidence of the patient to get a correct diagnosis. So when you are in doubt about the diagnosis about any skin lesion, just try calamine lotion. Make you maybe good. Make you. Thank you for your patient here.
Thank you, Dr. Najiba Riaz, for the excellent talk on applies to pediatric dermatosis. Now that is time for questions. There are no questions in the chat box. If you have any doubts, you can unmute and ask. Any questions?
Hello.
Hello.
Yes. Diagnosis of nutritional dermatosis and its treatment. Kindly elaborate.
Okay, nutritional dyschromia is called. Usually present as a ill-defined hypopigmented macules without scaling. You can see that in pityriasis alba and all, there will be scaling, but here no scaling. That's no one scaling. Point. And the margin, irregular patches you get. Whereas pityriasis alba will be usually circumscribed. Here,
okay.
Ill-defined lesions. And there will be, usually there will be pallor. This is due to deficiency of iron and multivitamins. So the pallor is always associated.
Anything to be applied external?
Need not be. You can apply emollients only. That's all. You correct the nutritional status.
Okay.
Whereas in pityriasis alba, which I showed, the circumscribed lesion with
circumscribed.
That's an endogenous eczema. You can give mild topical steroids. Pityriasis alba.
Okay.
There is a question in the chat box.
Yeah.
Well, I shall read. What is treatment for scabies during infancy?
Scabies also, we give the same treatment, permethrin is given. Same treatment is given overnight. Permethrin 5% cream, single application overnight for 10 to 12 hours.
Madam,
any other questions?
Madam, this for pediculosis, you mentioned about ivermectin cream.
Yeah.
See, ivermectin, how often and how many times you need to apply?
Usually, most of the pediculi is by single application. Very effective for pediculosis.
So
you apply
how
this
much time?
10 minutes only. You apply the shampoo-based preparation on all over the scalp. Keep it for 10 minutes and just wash it off. Because it is shampoo-based, no need for any other shampoo.
And this permethrin we need to apply for 3 weeks, 3 times weekly or?
Permethrin is a slightly longer time. You can apply 1 hour. But better response we are seeing with this ivermectin.
Okay, thank you.
Another question, should we repeat permethrin? That is another question.
For scabies, only if lesions persist, only if there are lesions, you have to repeat after 1 week. Otherwise, no need. You can wait for 1 week.
There is another question, which soap is good for dry skin of children?
So many moisturizing soaps are now available. The brands, should I say? I don't know. Dermadew. So general soaps, the best is Dove, the most moisturizing. And there are solutions also, body washes also available.
There is one more question. Ivermectin shampoo from which age we can use?
Any age, topic. No problem. It's a local application. Ivermectin systemically from about 3 years.
Any other question?
Ma'am, excuse me. Ma'am, for scabies, if the symptoms are persisting, no lesions, if the symptoms are persisting, should we repeat ivermectin?
It's better to repeat because there may be some mites.
Okay, ma'am. After 1 week?
Yeah, usually repeat earlier. The minimum period is 1 week. You repeat after 1 week.
Okay, thank you.
If there are no more questions, we will stop this session and go to next session.
There is one question in the chat box. Facial lesions.
Yes, I shall see.
For facial lesions.
Effect of application of oils in atopic dermatitis.
Yeah, you should remember that no oil should be applied on the skin. That will aggravate dryness. Already the atopic skin will be dry. So when you apply oil before bath, what happens? Water will not enter. There won't be any hydration. So before bath, you should not apply any oil. That's it.
Another question for facial lesions of scabies. What is the treatment?
So after specific treatment, you can give mild topical steroids for because it's a hypersensitivity response, this itching. For facial lesions, first, when there are facial lesions, you have to apply on the face as well. Otherwise, you apply below neck. And if there is itching persisting, you can give mild steroids after specific application.
Madam, can we apply this virgin coconut oil in atopic dermatitis after the bath?
After a bath, there's no problem. You can apply. Only before bath, you should not.
Treatment of cradle cap.
Cradle cap is the early stage of seborrhea. Use warm oil application.
Can shampoo be used?
Yeah, baby shampoos are there. Some.
What is the treatment of premature graying?
Premature graying, now we have found that it's due to deficiency of there are several causes for premature graying, but of late we have seen that vitamin D deficiency in most of the patients with premature graying. So when you check for vitamin D, so supplementation of vitamin D has been found to be effective in premature graying.
Another question, treatment of eczema for 1-year-old.
Which eczema? Atopic. Any eczema you can give when the acute stage is over, you give mild topical steroids. So like I have shown that mild steroids ending with son.
Scabies, Crotorax, what is how it is useful? Crotorax in newborn scabies.
Vaccine.
Crotorax.
Yeah, Crotorax was previously mentioned, but it's not available nowadays. Otherwise, it's effective if available. But I doubt whether it's available now.
There are no more questions in the chat box. If there are no other questions, we'll go to the other talk. Thank you, Dr. Najiba Riaz, for the excellent talk on approach to pediatric dermatosis and also for the excellent question and answer session. Thank you. Thank you very much.
Thank you so much.
Welcome. Next talk is by Dr. Riaz on rash and fever in children, something new, something not very new. Now I invite Dr. V. Parameswaran to introduce Dr. Riaz. Dr. Riaz actually needs no introduction. Dr. Parameswaran is his classmate and close friend. I invite Dr. Parameswaran to introduce Dr. Riaz. Over to Dr. Parameswaran.
Respected President Dr. Akbar, office bearers, my dear friends and seniors. I am to introduce my close friend, my younger brother, Dr. Riaz. He is hailing from Calicut. He is the grandson of our freedom fighter, Muidu Malavi. He has close relation to Malappuram. His father was district forest officer, and his early childhood was in Nilambur, and high school education was at Nilambur, and he passed the SSLC from Manavathan High School, Nilambur, as the topper of the school. After PG in periods, he did DM from Trivandrum. He is the recipient of FRCP Glaxo. He worked in all the medical colleges of government medical colleges in Kerala. He retired from the Calicut Medical College as the professor and HOD of pediatrics. Now he is the professor and HOD of pediatric gastroenterology, KMCT Medical College, Calicut. He is the author of textbook of pediatrics, gastroenterology and hepatology, 4th edition. This is the first Indian book on pediatric gastroenterology, and his first author. This is a fast-moving book. Another book is Review of Pediatrics. Frequently asked questions for pages. It's also good for pages. He has written several chapters in pediatric gastroenterology and textbook of pediatrics. He is happily married to Najiba Riaz. She has already talked to you. The son is Faiz, dermatologist at Ikra Hospital, Vadakkad. Daughter in Department of Radiology, Calicut Medical College. Then daughter is Roshni. She is a dermatologist at Perlamanna, married to Dr. Anish Ahmed, endocrinologist at Perlamanna. Both are having, Riaz and Najiba are having practice consultation at Perlamanna on every Sunday. He is the first pediatric gastroenterologist in Kerala. With these few words, I introduce Dr. Riaz to you. Over to Riaz. Okay.
This topic has very good significance during this COVID pandemic season. Over to Dr. A. Riaz for the talk on rash and fever in children, something new, something not very new. You can screen share.
Yeah.
Any problem?
Very minute നോക്കട്ടെ.
Share content.
ഒരു മിനിറ്റ് ഏട്ടാ. കാണുന്നുണ്ടോ? ഹലോ?
ഇല്ല, കാണുന്നില്ല. You can share the content and go to PowerPoint presentation in the laptop. Yes.
കാണുന്നുണ്ടല്ലോ?
Yes, കാണുന്നു.
Yes, yes.
So I would like to, am I audible, Permission?
Yes.
Okay, okay.
Audible.
I would like to thank Team IAP Malappuram, especially my Jigri Dost and brother, Dr. Parameswaran, Dr. Joshi, Dr. Jose Anthony, Dr. Jalil, Dr. Sadat, Juman, and all of you for this honor. Rash and fever in children. Rash and fever are some common problems encountered in pediatric practice. They're almost always seen in the same patients. So they can be referred to as the Siamese twins. The children with rash may be seen by pediatricians as well as by dermatologists. So this topic is of importance for pediatricians as well as for dermatologists. So I shall discuss the etiology of fever and rash in children, followed by a discussion of some of the serious diseases present with fever and rash through case scenarios, and I'll try to make it an interactive session. I may be asking questions, and if possible, you can write the answers in the chat box. Parameshwara chat box and no get answers. Parameshwara? Okay. So, Sir William Osler, the father of modern medicine, had remarked decades back that he who knows syphilis knows medicine. This is because syphilis is a great mimicker of disease. It can mimic almost any disease. But the present dictum should be that he who knows fever and rash knows medicine, because almost any disease can present with fever and rash. So I'll go through some of the basic skin lesions. So what is the So a macule is a lesion which is less than a flat lesion, which is less than 5 millimeters, called macule, and larger lesions are called patches. So in this child, you can see a macule as well as a patch. What the diagnosis? These are actually cephalomacules in type 1 neurofibromatosis. Now, raised lesions which are less than 5 millimeters are called papules, which is raised lesions which are more than 5 millimeters are called plaques. And here you can see papules as well as a forehead plaque in a child with tuberous sclerosis. Fluid-filled lesions which are less than 5 millimeters are called vesicles. Classic examples being chickenpox and HFMD. Whereas lesions, fluid-filled lesions which are more than 5 millimeters are called bullae. Classic example being bullous impetigo in children. A lesion with a visible accumulation of free pus is called a pustule. Now, spontaneous bleeding into the skin can be classified into 3 types depending upon the size. The smallest lesions are called petechiae. In between, we have purpura, and the larger lesions, which are more than 5 millimeters, are called ecchymosis. A rash is a vital diagnostic clinical finding, and many a time it's also a life-saving clinical finding as well. Speaking of clinical findings, I'm always reminded of our great teacher, Professor Gopi sir. It's indeed unfortunate that most of you in this audience will not be knowing Gopi sir. Gopi sir was an excellent clinician. And when we were doing our final year MBBS in the late 1970s in Calicut Medical College, one of the house surgeons was posted in pediatrics infectious disease ward, was admitted in the Department of Medicine with high fever, and he had a peculiar rash. He was very sick. He was almost dying. So Gopi sir was called in for a consultation. Gopi sir just took a look at the patient and said, "These are purpura, do an LP to rule out meningococcal meningitis." And he was absolutely right, because the CSO was turbid. And by that time, the patient went into shock, and he developed all the non-complications of meningococcal meningitis. But ultimately, his life could be saved. But that was only because of the clinical acumen of Gopi sir. If Gopi sir had not correctly diagnosed this as purpura, an LP might not have been done and would have died. And incidentally, this house surgeon later went on to do his post-graduation in pediatrics with me in Calicut Medical College. And he was a very flourishing pediatrician in Palakkad for a very long time. Of course, he died a few years back of an entirely unrelated disease. So a rash may be diagnostic of very serious conditions like meningococcemia, as you just now seen, and a score of other conditions also like collagen vascular diseases, Kawasaki disease, drug-induced rash, rickettsiosis, etc. So rash may be due to various types of infections, which may be viral, bacterial. It may be due to drugs, and there's a condition called DRESS. It may be due to collagen disease or even malignancies like leukemias in children. Now here you can see a change in the dressing pattern of Bollywood heroines. Now who is this? Can anybody spot this beautiful lady? She's actually one of the most beautiful heroines of the 1950s and 1960s. Paramacharan chat box lady. Who is this? Well, she was the heroine of
Madhubala.
Right. She is the heroine of Mughaliya's Madhubala. Incidentally, she had a pediatric disease also. She had an undiagnosed congenital heart disease, VSD, which was diagnosed only very late. Unfortunately, she developed all the complications, including maybe the various complications, and she died of the complications of VSD at the tender age of 35 years. So look at Madhubala, how modestly she is dressed. Let's see now. The dream girl is all modestly dressed. But this is how the latest actors are dressing. There's a big change in the dressing pattern of Bollywood heroines. Similarly, there is a big change in the infectious agents which are hitting us, thanks to air travel, which is the international air travel, which has become very popular now, and also these vectors. So if there is an infectious agent, a new infectious agent, a viral hemorrhagic fever in Bolivia in South America, that can reach Dubai in 14 hours. And from Dubai, it can reach Calicut within just 4 hours. That means a very serious infection from South America can hit Calicut in about 18 hours. And what is this? This is anybody, what is this area? This is the notorious Wuhan market from where the COVID-19 erupted. And this reached Calicut and it reached Kerala, especially Trichur, just last year. And rest is history. I won't go into that. How do you approach a child with fever and rash? Suppose a child comes to you with fever and rash. What is the first step? Well, I'm actually very fond of this slide because the first step is history taking, the second step is history taking, even the third step is history taking. I written history 3 times only to underscore the importance of taking proper history, because if you do not take a proper history, you are sure that you will miss the diagnosis. Then you examine the patient and do the relevant investigations. So pediatricians should definitely be like Sherlock Holmes. And I always believe that not only pediatricians, all doctors should be inquisitive like Sherlock Holmes. Now let's see a case scenario. We had an 18-month-old immunized child. You can see that I have highlighted immunized child. And he developed a sudden or abrupt onset of high-grade fever. He was looking very sick. On the 3rd day of the fever, he developed maculopapular rash of the trunk. And suddenly or abruptly, the fever completely subsided. The child looked fine. So here is a child, an 1.5-year-old child with a high-grade fever, was looking very sick. On the 3rd day of the fever, he develops a rash, and then the fever completely subsides. The child looks fine. So this is called the rainbow following a storm appearance. The storm is a high-grade fever, and after the storm, you get a rainbow. Now, what is the diagnosis here in such a picture? Permission, anybody in the chat box? With this picture, what should be your diagnosis? Permission, anybody in the chat box?
Nobody.
This is roseola infantum. I'm afraid we do not usually speak of a roseola infantum or exanthem subitum.
Exanthema subitum is there in the chat box.
Pardon?
Exanthema subitum is in the chat box.
That's right. Roseola infantum. Another name is exanthem.
By Dr. Habib.
Habib is my old student working now in Batteri. Okay. So roseola infantum or exanthem subitum is also known as the 6th disease. It's caused by the 6th herpes virus. It's also known as a 3-day fever. It's also called the exanthem subitum or pseudo rubella because it resembles rubella to some extent. No, absolutely no problem. Sudden onset of high-grade fever. Child looks very sick. Then he develops a rash and the fever subsides. It is called an enanthem also, which is called the Nagayama spots. It's got a very good prognosis. And these children have got a very characteristic facial because of a palpable eyelid edema. So because of the presence of eyelid edema, they have got a sleepy appearance. So if a child with high fever has got a sleepy or a droopy eyelids, then it may help us to make a diagnosis of roseola infantum before the rash appears. That is the pre-eruptive stage. You can make a diagnosis of roseola infantum. This is a classic spot in pediatrics. I'm sure you know the diagnosis. That is herpes zoster in the dermatome. Now, this is a clue for you. This helps you to diagnose which condition. What are we seeing here? Yeah, that's what you are seeing, dew drops on rose petal. So this is the classic appearance of chickenpox, dew drops on rose petal appearance. Suppose child with fever and rash is irritable and is unimmunized. Think of measles. Suppose the child is extremely irritable. Think of Kawasaki disease. Child is very sick, is in shock. Think of meningococcemia. Look at the oral cavity. In measles, you may find Copic spots. In rubella, you may find Forsheimer spots. And in Kawasaki disease, you may find strawberry tap. What is this? What is this? And what's the significance in pediatrics? You can see that this is the tiger mosquito or the Aedes mosquito. So this is the causative agent of chikungunya, which can cause hyperpyrexia and it can cause a rash. This rash may be either maculopapular rash or petechial rash. And this rash has got a peculiarity. This can involve the nose, producing a persistent pigmentation in the nose. And it can cause severe arthritis, headache. Now, you know that we had an epidemic of chikungunya in 2010 and 2011, and the Department of Pediatrics and Dermatology had conducted a camp in Perambra, and we found a lot of patients with this peculiar, this is called a chick sign. So we go to the internet and click chick sign, you'll find this photograph. Even infants and neonates were afflicted with chikungunya. You can see the peculiar lesions, skin lesions, the charred skin lesions of chikungunya in infants. This child also had high-grade fever and he's got a very peculiar rash. What is this rash? You can see this rash, the white islands in a sea of red. So the whole body is erythematous and in between you can see normal skin. So white islands in a sea of red. This is suggestive of dengue fever. Now, any takers for this? You can see that there is the inflammation of the orifice of the Stensen's duct of the parotid duct. This sign is called the Tresillian's duct sign. So if this duct sign is positive, the Tresillian duct, that is the orifice of the Stensen's duct is inflamed, the parotid duct is inflamed, that will help you to make a diagnosis of mumps, even before the patient develops parotitis. I had discussed this with some of my postgraduate students in 2010 and 2011, and I'm happy that one of my best students, Dr. Sam, diagnosed a case of mumps recently just by looking at the Tresillian duct sign. Now, you know that rubella is usually it's an innocuous, harmless disease, except in pregnancy. If a pregnant lady develops rubella, that is going to be catastrophic because that can cause a condition called the congenital rubella syndrome or the Griggs syndrome, which is characterized by microcephaly, congenital heart disease, cataract, severe intellectual disability. It's very difficult to rear children with the congenital rubella syndrome. But nowadays, it's very difficult to say congenital rubella syndrome. Why is it so? This because of the MR vaccine campaign, which was initiated by Dr. T.P. Ashraf, one of the best pediatricians of our state. And he was also responsible for implementing the cochlear implant program. And through the cochlear implant program, many children with congenital rubella syndrome, who were deaf children with congenital rubella syndrome, started speaking again. Now, what is this? This child has got a peculiar rash on the face and lace-like rash on the extremities. This condition is called the fifth disease or the Erythema Infections, which is caused by parvovirus virus. This is also relatively benign disease. But if a pregnant lady contracts Erythema Infections, then the baby may develop very serious conditions like hydrosphitis. And the baby and a child with a sickle cell anemia, if is exposed to the parvovirus virus, they can develop aplastic crisis. So this is the significance of Erythema Infections, which is otherwise an innocuous disease. I'm sure you'll be bored if I talk to you about COVID, because I'm sure that you listen to COVID talks on COVID a lot of times, except to say that a lot of skin lesions have been described in COVID. This is the COVID toe in a child as well as COVID toe in an adult. In fact, a study was conducted in Italian children with COVID. They found that a lot of Italian children who did not have any other features of COVID, they presented with this lesion alone. Okay, they are diagnosed with COVID subsequently. So this lesion may be that the COVID toe may be a marker of COVID infection. So if a patient with such a lesion or the toe comes to you, you should please rule out COVID. So what is the most common rash of COVID-19? Anybody in the chat box, Parameshwaran, what is the most common lesion, skin lesion of COVID-19? Parameshwaran, anybody in the chat box?
No.
You know that we are all obsessed with the sanitizer. So we go on applying the sanitizer. According to the Guardian, the most common skin lesion nowadays is sanitizer dermatitis. You know, sanitizer is a chemical substance. If you apply it very frequently, many of us will develop dermatitis. So sanitizer dermatitis is in fact the most common skin lesion of COVID-19 nowadays. Now we'll go to a clinical scenario. What happened in Calicut Medical College in 1997? So I was working with in the unit of Srigumaran sir. Srigumaran sir is one of the best pediatricians. He was my teacher, he was my mentor. So he was my unit chief also. So I was working in his unit. And we came across a 5-year-old unimmunized girl with a high fever who was not responding to any treatment, antimicrobials, paracetamol. She was very much irritable. She had a maculopapular rash on the trunk. Systems were within normal limits. She had sterile pyuria. So because of the pyuria, she was put on ampicillin. You can see that she has got leukocytosis, neutrophilia, ESR is high, platelet count is normal, CRP was positive. With this clinical picture, in 1997, what will be our first diagnosis? Not now. 1997, naturally, our first diagnosis, urinary tract infection. We thought of the possibility of viral exanthem, a drug rash, but even though we are sure that it is not viral exanthem or drug. Now it's very easy to diagnose Kawasaki disease, but this happened, remember, in 1997. Okay. On the 8th day of the illness, the fever was persisting, developed cervical lymphadenopathy, non-purulent conjunctivitis. So we were actually wondering what was happening to this child. The 10th day, the child continued to be sick, developed abdominal pain. ESR shot up to 120. Then we did a little plate. We found that the platelet count was reported as 12 lakhs. So myself and Srigumaran sir got angry with the technician who reported the platelet count 12 lakhs. So we called the technician, what are you saying? Can the platelet count be 12 lakhs? But this technician was a very serious, very sensible person, very sincere and sensible person. He said, sir, it is 12 lakhs, I will repeat it. Then he repeated and said it is more than 13.5 lakhs. Then we did a peripheral smear and found that he had a striking thrombocytosis. And this was how we diagnosed the first case of Kawasaki disease in 1997. And we did an ultrasound, we showed high drops for the gallbladder. The Kawasaki disease was actually described by the famous Japanese pediatrician Tomisaku Kawasaki way back in 1967. Okay, the first case in India was reported in 1977 by Tanij et al. Later it was reported from Toronto Medical College by Noel sir. The classic age group is children below the age of 5 years. Now, who are these? Anybody? Parameshwaran, anybody in the chat box? Can you spot this famous Hollywood actors?
Nobody in the house.
Pardon?
Nobody.
Nobody. Okay. They actually the Travolta family. John Travolta, his wife, and the son, Jet Travolta. The Travolta family was in news a few years back for a very unfortunate reason, because Jet Travolta suddenly died of a mysterious illness, which is diagnosed to be due to Kawasaki disease. With this, Kawasaki disease caught the attention of medical personnel all over the world, and there has been a lot of research subsequently on Kawasaki disease. So even after 60 years after description, we still are not very sure of the etiology. So etiology continues to be enigmatic. Even if we do postulate some etiology, we do not know the exact pathophysiology. Okay, so pathophysiology continues to be elusive even now. So since the etiology and pathophysiology are not very clear, the pediatrician will be forced to give newer and newer modalities of treatment. So treatment is said to be heroic. In spite of that, sometimes the child may die. So the prognosis is to be perplexing. This in a nutshell is Kawasaki disease. So Kawasaki disease is the most common cause of acute heart disease in children in the Western countries. Even in developing countries like India, it's fast catching up with rheumatic fever. And it's one of the very important causes of myocardial infarction and acute heart disease in children, even in India. Anti-rheumatics may be seen in 70% of children now with ocular findings. So sometimes a street lamp examination will be helpful in the diagnosis in doubtful cases or ambiguous cases of Kawasaki disease. There's a famous dictum about rheumatic fever. That is, rheumatic fever licks the joints and bites the heart. And JIA licks the joints and bites the eyes. Now, what does Kawasaki disease do? Well, Kawasaki disease licks the joints and the mucosa and bites the coronaries. So this was one of our first patients with Kawasaki disease. You can see the old Ward 55. This ward has been completely renovated thanks to the brilliant efforts of our Superintendent, Dr. Ashraf. Another patient with Kawasaki disease, you can see the red lips, edema with hands and feet, the strawberry tongue, the rash of a Kawasaki disease. It may be macular, it may be macular papilla, it may be targeted. Sometimes there can even be psoriasis impressions. The importance is that if you find vesicular or bullous lesion, this is very unlikely to be Kawasaki disease. You don't expect vesicles and bullae in Kawasaki disease. Non-purulent or non-purulent conjunctivitis is another classic feature. Notice this. Here is a palmar erythema and the Buse line in Kawasaki disease. In the second week of the illness, there will be desquamation which starts from the peduncle areas. It can progress. And in one of our patients, the entire skin of the sole completely peeled off. You always examine the genitalia of patients with the suspected Kawasaki because sometimes there may be lesions in the genitalia. And sometimes there may be an unexplained sudden accentuation of the BCG scar. The BCG scar, which was very inconspicuous, suddenly becomes accentuated. Think of the possibility of Kawasaki disease. What are the other causes of strawberry tongue? Is it pathognomonic of Kawasaki disease? No. It may be seen in scarlet fever, it may be seen Riley-Day syndrome or familial dysautonomia and other conditions like Top-Stop syndrome also. Now, what is the classic skin lesion of scarlet fever? Remember, scarlet fever is not that common lesion. I think we are not diagnosing lots of scarlet fever. That does come in the differential diagnosis. The classic skin lesion of scarlet fever is, anybody in the chat box? Anybody in the chat box? What is the classic skin lesion of scarlet fever? It is a Pasteur's line. You can see the Pasteur's lines here. Can you see the Pasteur's lines? And the sandpaper rash. Sandpaper rash. You can see the sandpaper rash of the trunk and the Pasteur's lines in the cubital fossa. Finding common to scarlet fever and scarlet and Kawasaki disease, both may develop, the child may develop strawberry tongue. The strawberry tongue may be seen in both scarlet fever and Kawasaki disease. Now, Keralites are very fond of indoor or outdoor sports. From Calicut, where do they go? From Calicut, people usually go to Wayanad area. So we had a 12-year-old girl from Calicut who went for trekking in Wayanad. She had a nice time for 2 days in Wayanad. And then she came back to Calicut and she developed a fever, headache, vomiting, abdominal pain. Okay, she was looking very sick. Conjunctiva congested, she had periorbital edema, she had hepatomegaly, no splenomegaly. Look at the bloods, leukopenia with neutrophilia. Platelet count was low. Transaminase was mainly elevated, years about 65, her chest X-ray was normal. So this child was admitted in a private hospital in Calicut because of a high-grade fever. She was treated with multiple antimicrobials, including even meropenem, but there was absolutely no response. So she was referred to IMCH and we admitted the patient to IMCH, and one of our brilliant postgraduates picked up this clinical finding. What is this?
Right.
That is an SR. Okay. This was an SR which is actually covered by a blouse sleeve. That was an SR which resembled the skin burn of a cigarette butt. So with that, you can see that she had a macular papillary rash which has extended to the palms and soles also. Her wheel Phillips test was positive, and we put her on doxycycline. Just doxycycline, you can see the response. The moment within 24 hours after starting doxycycline, her fever subsided. So a rapid effervescence with the doxycycline may be used as a diagnostic test for scrub typhus. So this is the rash. A rash may be seen on the second week of illness usually, but it's seen only in 1/3 of patients. Sometimes the rash may be macular papilla or even vasculitis may be seen. This is Howard Taylor Ricketts who described this condition, but unfortunately he died of Rickettsian infection at the tender age of 38 years. Now, the scrub typhus is very common in Australia, Southeast Asia, the entire Indian subcontinent. So this is known as the Suzuki-Amishi triangle. So countries belonging to the Suzuki-Amishi triangle, scrub typhus is very common. Why are we bothered about scrub typhus? Because before the advent of COVID infections, we had a lot of patients with scrub typhus. It is notoriously difficult to diagnose. And if you do not treat it correctly, the patient might die. Diagnostic clues: a sick child with pyrox of unknown origin. We don't have a diagnosis. There may be history of tick exposure. The characteristic rash may be seen only in 30%. Leukopenia, but neutrophilia and low serum sodium may be helpful. The differential diagnosis of scrub typhus may be dengue. Remember that even COVID-19 comes in the differential diagnosis. So what are the tick-borne diseases? The most common tick-borne disease we just mentioned, that is scrub typhus. That is followed by KFD. KFD is Kiesonoid forest disease. And there are other conditions also that are not very common in our country, like Lyme disease, babesiosis, ehrlichiosis, etc. Now, what is this and what is the relevance of this in pediatric dermatology? Anybody? What is the relevance of this in pediatric dermatology? Permission arengilo chat box no. So this is bullseye. So what is the relevance of this in? This is a bullseye rash. Which condition you will get a bullseye rash? Bullseye rash is seen in Lyme disease, and the description of the lesion is Erythema chronicum migrans. Erythema chronicum migrans is the classic skin lesion of Lyme disease. This resembles a bullseye. Now, anybody who is this? Permission area. Who is this? Darila. This is Sabida.
Sajida.
Yeah, Sabida belongs to 35th batch. Sabida was one of the most brilliant postgraduate students I ever seen. She's a brilliant pediatric endocrinologist. I had nicknamed her as the walking Nelson. Okay? Because she was a thorough listener. She could spot anything in Nelson. She's currently working in the US, and she's working in an area which is near Lyme, that is Connecticut. That's the relevance of Sabida in this discussion. And Sabida's sister Sabida is like a brilliant dermatologist working in the department, the dermatology of Health America. That is Sabida. Anyhow, Lyme disease, the organism is the Borrelia burgdorferi. The vector is the ixorid ticks. It causes fever and migratory polio-arthritis. The importance is that this can cause migratory polio-arthritis, and hence it may be mistaken for rheumatic fever. Just like rheumatic fever, it can cause skin lesion as well as carditis and also heart block. A few cases of Lyme disease have been reported from Haryana in India. So it's possible that it may be present in Kerala also. Now, what is blast? Have a heard of a blast? And what is the relevance of blast? Blast is actually an acronym for tick-borne diseases. Blast. What is blast? B. Bathe within 2 hours of coming indoors. If you are working in if you are going out to a tick-infested area, you have to take a bath as early as possible. Look for, L stands for look for and remove ticks on your body. A. Apply repellents to your body and clothes. S. Safeguard your surroundings from ticks. And if you've got pets, you should treat your pets also. This was actually introduced for Lyme disease. But I'm sure that this is applicable for all tick-borne diseases, including. Let's see another case scenario. We had an 8-year-old girl with again with pyrox of unknown origin. She had diarrhea. Interestingly, her parents and 3 cousins also had a very similar illness, that is fever and diarrhea. She had an erythematous macular rash on the trunk. She had hyperplasia. The clue was that they had been to pilgrimage recently. Look at the blood. She has a leukopenia. ESR is the high, mild elevation of transaminases, and mild conjugated jaundice. So that means she has got hepatitis also. So with this picture, what could be the diagnosis? She has got an erythematous maculopapular rash, hyperplasia, leukopenia. What could be the diagnosis? Anybody in the chat box? Parmeshwaran? Diarrhea, PUO, pilgrimage, hyperplasia. That is, diagnosis is, this is enteric hepatitis. So what is the skin lesion called? Skin lesion is rose spot. So this is the classic rose spot. It is actually difficult to demonstrate in our skin because of our brown color, but sometimes it may be seen. So these are rose spots. So this patient had enteric fever. Now, how will you proceed with the evaluation of this child? I will give a clue for the evaluation of this particular patient, that is this man. Now, who is this? Chat box. Paramesh, anybody in the chat box? Who is this?
Jyoti Basu.
That is Jyoti Basu. So how does Jyoti Basu help you to diagnose the enteric fever? Well, Jyoti Basu, the Basu is actually an acronym for the diagnosis of enteric fever. Blood culture becomes positive in the first week. Agglutination, that is viral, in the second week. Stool culture in the third week. And urine culture in the fourth week. So even politicians can help you to diagnose enteric fever. There's another patient with peculiar skin lesion, fever, bright red tender plaques. And these plaques have got distinct borders, and the lesion spread very rapidly. Child had fever, he was looking sick. This is the classic presentation of erysipelas. Okay? It is caused by group A beta hemolytic streptococcus. The drug of choice is penicillin, macrolides and clindamycin are also effective. What's the importance of erysipelas? Now, erysipelas may be mistaken for cellulitis. So erysipelas is actually an infection of the upper dermis and lymphatic, whereas cellulitis is an infection of the deeper dermis and subcutaneous. Suppose the patient develops, this patient has got a facial lesion. So we thought that was a facial cellulitis. But then, you know that the pinna descended dermis, deep dermis and subcutaneous tissues. So in cellulitis, pinna will not be affected. But here, this patient with suspected cellulitis of the face, for example, you know that H influenza is not Haemophilus influenza HB. Haemophilus may sometimes cause facial cellulitis. But this is actually erysipelas and not cellulitis because the pinna is involved. The pinna involvement is suggestive of erysipelas rather than cellulitis. What is this sign called? This is a classic sign of dermatology or pediatrics. Anybody in the chat box? What is this sign called? Involvement of the pinna in erysipelas. Permission, are you No. No.
No.
This is millions. Yeah, that's called millions ear sign. So in facial cellulitis, suspected facial cellulitis, either is involvement of the ear, that's called million ear sign. This is likely to be erysipelas and not cellulitis. Another case, a first-year medical student moved to the hostel, and 1 week later, she developed peculiar skin lesions. She had 3 groups of pruritic papules on the trunk. What's the most probable diagnosis? Can anybody spot the diagnosis? So she is a medical student, she has moved to the hostel, and 1 week later, she developed pruritic papules in the trunk. Anybody in the chat box? What could be the diagnosis? You remember, I recall our hostels.
Simicosis.
Simicosis, absolutely. Vasu is my classmate. Thank you, Vasu. Vasu is a brilliant dermatologist. She belongs to my own batch, the Sweet 17 batch of Calicut. Myself, Dr. Vasu, Paramesh Rana, Shahabudin, we all belong to the 17th batch of Calicut Medical College. This is bed bite or simicosis. So that is a breakfast, lunch, and a dinner rash. The bug is supposed to bite the victim 3 times. He takes a feast or 3 times. That's called the breakfast, lunch, and dinner. It's also known as the BLD rash. Breakfast, lunch, and dinner rash or the BLD rash. Suggestive simicosis or bed bug bite. Another case where a 6-year-old boy with a recurrent seizures was put on lamotrigine. Okay. So after 3 months, he developed high fever, erythema of the face, and a macular rash of the trunk. So this rash was attributed to the amoxicillin, which was started 5 days back for lower respiratory tract infection. So this child on lamotrigine was put on amoxicillin. He was developed a macular rash 5 days later. But he was looking very sick. He had jaundice, facial edema, lymphadenopathy. His mucosa were normal, which means that these are unlikely to be Stevens-Johnson syndrome. He also had hepatosplenomegaly. Okay. He had leukopenia, thrombocytopenia, and the eosinophil count was a whopping 75%. Okay. You can see that his RFT was deranged, his creatinine was 3.5 mg/%, transaminases were elevated. What's the diagnosis? Anybody in the chat box?
Yes, trust.
Yeah, that's right. Absolutely right. Yeah, absolutely right. So this condition is called DRUS. So what is DRUS? DRUS is an acronym, drug reaction with eosinophilia and systemic symptoms. one of the most challenging problems encountered in pediatric dermatology and dermatology practice. It's also known as drug-induced delayed multi-organ hypersensitivity syndrome. Can mimic viral infections, neoplasms, or even autoimmune diseases. Got a very high mortality to the tune of almost 10 to 50%. These are some of the drugs implicated. The drugs in red are the commonly used drugs in pediatrics. Phenobarbital, phenytoin, lamotrigine, ampicillin, esomeprazole. We use a lot of esomeprazole also. And of course, this is hydroxychloroquine, which is very popular for the treatment of COVID-19. Of course, we are not using hydroxychloroquine nowadays for COVID, but the hydroxychloroquine is also notorious to cause stress. What's the problem? The importance is that usually a skin rash following usual drugs like ampicillin and amoxicillin appears within 3 to 5 days. But this may be delayed. The relation may be delayed for 2 to 6 weeks, up to sometimes 3 months. And the triad is fever, rash, and multi-organ involvement. And this can have long-term sequelae. The patient may subsequently develop autoimmune diseases and end organ failure. So this is a very serious disease. The dictum is always look beyond the skin. Okay, look at the respiratory system. There may be pneumonia. Look at the liver, the kidneys. So that is just for it. Now, this is another patient who presented with polio arthritis, high-grade fever and polio arthritis. Arthritis involving multiple joints, large joints as well as small joints. He had a hectic temperature. They got remittent fever. You can see that it doesn't touch the baseline. And they develop a peculiar rash like this. So what is this type of rash called? What is this fish called? This fish is the salmon fish. So this type of rash is called a salmon-colored rash. And it was described by a person called Sir Frederick Still. So it's also known as Still's rash, Still's disease, Still's rash. So that is salmon-colored rash. The diagnosis is JAI, juvenile idiopathic arthritis. So this rash may be seen at the height of fever, and the rash may fade as the temperature becomes normal. It may reappear with the next fever spike. These are the common sites. Remember that sometimes the rash of rheumatoid arthritis, it may demonstrate the Koebner phenomenon. Interestingly, sometimes the rash of Soja may be intensely pruritic as well. This is another classic spot of pediatrics. I'm sure you know the diagnosis. What the diagnosis? Sure, most of you diagnose this condition. Paramecitin. You can see the photophobia. Paramecitin, anybody in the chat box? Diagnosis?
SLE.
Yeah, this is a classic case. You can see he's got a photophobia, the classic lesion, the facial lesion, the mucosal involvement, and the alopecia. This is SLE. Now let's see another case here. But a 12-year-old inmate of a madrasa who presented with fever, headache, myalgia of 24 hours prior to admission. He developed neck rete. He was found unconscious in the madrasa. He was rushed to the ICU of Calicut Medical College, where he had these lesions. Okay. For the diagnosis, you can see these are purpura and ecchymotic lesions. In a child who is unconscious with purpura and ecchymosis, think of meningococcemia. This CSF was turbid. Gram-negative cocci could be demonstrated. He died, unfortunately. You can see the hemorrhagic brain. What is this? What's the finding here? Anybody? Parameshwar, anybody in the chat box? Is the pathology? You can see that he has got, these are the kidneys, and you can see adrenal hemorrhage, bilateral adrenal hemorrhage. What the condition called? This condition is called Waterhouse adrenal hemorrhage or Waterhouse-Friderichsen syndrome. So this is usually following a crowded environment like Purim or a Hajj pilgrimage. And that's the reason why before going for Hajj pilgrimage, we have to take the meningococcal vaccine. So how do you evaluate a child with fever and rash? Evaluation. You can routine investigation may be helpful, like urine, CBC, CRP. Sometimes the peripheral smear may be very helpful because the EMN can be diagnosed by peripheral smear, infection molecular, serologic test for SLE, antinuclear antibodies, dsDNA, and the friendly the dermatologist may help you with a skin biopsy, which may help you to pick up difficult cases. So the location of the rash may sometimes help you in the diagnosis. For example, suppose there are lesions in the face, think of measles, or a lesion starting in the face and then spreading downwards. think of measles, rubella. And lesion in the face alone, think of erythema infections. We already see that the start cheek appearance. Lesions start in the face and the spreading down with vesicles, think of chickenpox. And roseola infant we are discussing details. If there are vesicles in the oral cavity and hands and feet, think of HFMD. Appearance of rash is also very significant. 5th day of fever rash, that's called measles. Measles in Malayalam is called the Anjam Beni. Why is it called Anjam Beni? Because on the 5th day of the fever rash appears. Munam Beni is actually rubella. Rubella actually on the 3rd day of the fever rash appears. 3-day fever is different. 3-day fever on the 3rd day rash appears and the fever subsides. That is roseola infanta. Now, before ending, I would like to show you this photograph. You can see that this is an old photograph taken in Calicut Medical College in 2003. All these children presented either to the pediatrician or to the dermatologist with fever and rash. But their rash, the rashes were petechial and purpura. So they were diagnosed to have leukemias. So all these children had leukemias. And in those times, in the early 2000s, the prognosis for children with leukemia was very bad. And most of these children have already died. But nowadays, we have got an excellent department of pediatric hemato-oncology, which is headed by a brilliant hemato-oncologist, Dr. Ajit Kumar, who is the head of the department of pediatrics also, and is ably supported by Dr. Sheetal, who has done a DM in pediatric hemato-oncology. So because of Dr. Ajit and Dr. Sheetal, we have got an excellent department of pediatric hemato-oncology, and the results in IMCH are almost on a par with the best centers in the Western countries. Now, what is the most important clue to the diagnosis of fever and rash? That is suspicion. Just like this famous Alfred Hitchcock thriller, Suspicion, starring Cary Grant and John Fontaine. Suspicion is very important. You should rule out. You should always consider the possibility of other conditions and rule out other conditions. If you do not suspect other conditions, you will never diagnose. So, to end, I would like to quote Sir William Moseley, the father of medicine. It mentioned that the young physician starts life with 20 drugs for one disease, while the old physician ends his life with 1 drug for 20 diseases. So, Sir William Moseley is advising us not to use too many drugs. And you know that drugs are notorious to cause rashes. Again, to quote Professor Theodore Woodward, was a brilliant physician. So, Woodward once remarked that when you hear hoofbeats, think only of horses and not zebras. Well, usually Columbine is caused by hoofbeats, not zebras. This is because the valid medical principle is that common is common and rare is rare. That means you should always think of the common conditions, don't think of the rare conditions. But in pediatrics, I would like to change it. That we should think of zebras also. Because if you do not think of rare conditions like the zebras here, you will miss some very serious conditions, some of which will be having very specific treatment. So always think of the rare conditions also. So take home messages are, rash and fever, that is indeed a very sinister combination. It may be due to a score of conditions like rheumatic fever, juvenile rheumatoid arthritis, SLE, meningococcemia, malignancies, Kawasaki disease. The most common cause of fever and rash in children is viral exanthem. 90% of children with the fever and rash may be having viral exanthem, whereas most adults with fever and rash may be having drug-induced rash. Most viral exanthems resolve without any specific treatment. And careful history and examination are vital. Thank you so much for listening to me.
Please close sharing the screen. Thank you, Ria sir, for the excellent talk on rash and fever in children. Now it is time for discussion. Let me see whether there are any questions in the chat box. Everything is clear. There is no question in the chat box. If there are any doubts, you can directly ask after muting.
Thank you, SRB. Thank you, SRB. Oh, SRB. Thank you very much. A Dasan from Kuwait. Dasan.
Dasan.
Parmesan Dasan from Kuwait.
Dasan is present.
Dasan belongs to 24th batch, one of my pet students.
CBC.
You are the CBC one. Now it's the CBC of Kuwait. Kuwait CBC. Pandu was the CBC of Valanjeri. Now is the CBC of Kuwait. Dasa Sugale.
Unmute Dasan.
Mute and talk.
Dasan
unmute.
Unmute Dasa. Unmute.
Unmute. Thank you, sir. Thank you very much, sir, for the nice presentation.
Dasa ചെറുപ്പായി വരുന്നുണ്ടല്ലോ ദാസ.
ഇന്ന് ഫ്രൈഡേ അല്ലേ സർ?
ഒന്ന് ലീവ് ആയിരിക്കും.
ഇന്ന് ലീവ്. ഫ്രൈഡേ വെച്ചോണ്ട് നന്നായി. പിന്നെ പേഷ്യൻസിന്റെ ഇടയിൽ.
Jumman belongs to the 44th batch. Hello.
Yes, sir. 44th.
There are no more questions. We'll stop the session. Once more, I thank Dr. Riaz and Dr. Najiba Riaz for the excellent talks. Now over to Dr. Juman for a vote of thanks.
Thank you, George sir. Respected senior leaders, Riaz sir, Najiba madam. It was a really fantastic presentation.
Really
Riaz സാറിന്റെയും അതുപോലെ തന്നെ മാഡത്തിന്റെയും ക്ലാസ് ഉണ്ടായി കഴിഞ്ഞാൽ അത് നമുക്കത് അറിയാം. അതിൻ്റെ ഒരു മിനിമം ഗ്യാരണ്ടി നമുക്കുണ്ട്. അത് നമ്മുടെ ടോക്കിൽ നമ്മുടെ CMEയിൽ അറ്റൻഡ് ചെയ്ത ആളുകളുടെ എണ്ണം നോക്കുമ്പോൾ നമുക്കത് മനസ്സിലാവും. 100ന്റെ മുകളിൽ 100 പേരാണ് മാക്സിമം നമുക്ക് ഇതിൽ പ്ലാറ്റ്ഫോമിൽ അവൈലബിൾ ആയിട്ടുള്ളത്. 100 നിറഞ്ഞ സമയമായിരുന്നു. ഇപ്പോഴാണ് കുറേ പേര് ഈ ടോക്ക് കഴിഞ്ഞപ്പോഴാണ് ലീവ് ചെയ്ത് പോകാൻ തുടങ്ങിയത്. എനിവേ വളരെ നല്ല രീതിയിൽ വളരെ ഇൻട്രസ്റ്റിംഗ് ആയിട്ട് അതേസമയം നമുക്ക് ക്ലിനിക്കൽ പ്രാക്ടീസിൽ വളരെ യൂസ്ഫുൾ ആയിട്ടുള്ള രീതിയിൽ ആയിരുന്നു 2 ടോക്കുകളും ഉണ്ടായത്. മാഡത്തിനും സാറിനും പ്രത്യേക നന്ദി, IAP മലപ്പുറത്തിൻ്റെ നന്ദി അറിയിക്കുന്നു. അതുപോലെ തന്നെ ഈ പ്രോഗ്രാമിൽ പങ്കെടുത്ത മുഴുവൻ സുഹൃത്തുക്കൾക്കും സീനിയർ ലീഡേഴ്സിനും എല്ലാവർക്കും ഒറ്റവാക്കിൽ IAP മലപ്പുറത്തിൻ്റെ നന്ദി അറിയിക്കുകയാണ്. JAP, ജയ് ഹിന്ദ്.
Okay, good night.
Thank you all.
Good night. Good night.
Thank you very
Bye.
much.
Yes, good night. Thank you.
Thank you and good night. Good night all.
Thank you.
Yes, sir. Thank you.
Okay, good night.
So, Adi, sit
Yes, sir.
here.
Okay, thank you.
Thank you, everybody. Good night.
Good night. Good night. Lil Sahib, good night.
Thank you all. Thank you and good night to all.
Joshi, good night.
Good night.
Night.
Thank you, sir. Thank you very much, sir.
Good night. Good night. Dasan. Okay.
Good night.
Good night. I'm ending the session.
Okay.
Thank you very much.